Yeah, that might be the same. Maybe somebody from the audience already wants to ask a question or comment on one of the statements being said before. Any questions to Sister Evelina, to Dr. Eriksen, or to Dr. Grisnicht? Yeah. Oh, sorry. The light is too bright.
Very nice presentations, and of course, very beautiful work to do out there. Do you think it's helpful for you during your daily work to have a telementoring system? So as Sister already told, it's very difficult to discuss with a colleague or with a supervisor or with somebody. Would it help to have somebody available on, like here in Amsterdam, with an iPhone and with a FaceTime connection and tell you what to do in a difficult situation or help you out with a difficult case? Would it help?
Yes, it would be helpful, but sometimes in rural areas, even surgery, we operate with the phone. So there is no internet. Mm-hmm. How can we have that connection? It's still very difficult.
But only a phone connection already would help, or is it also not possible?
No connection.
No connection. But that makes it very difficult, I understand. But if there were a connection, would you like to have a system, a network, to have doctors available?
Yes. It will have been very good, because sometimes you do abdominal surgery with assistants who is just helping you to retract. Mm-hmm. You can ask nothing. So you suffer brain and you see how can you help, nobody to ask. So very difficult. In case of getting anything to help will be very important and very good.
Okay. And for the other?
I think the timing can be a problem, right? Because the pre-operative planning is different than in, for example, the Netherlands. You have many acute cases, whereas Suzanne is proposing that if you can discuss a case on forehand, it can help you. But many cases, do you plan them, or many cases are acute?
Many cases are acute, and we have few diagnostic tools. So you enter in and you find what you get inside. So it's difficult.
No, but especially a network for also acute cases would be nice, I think. Yeah. But that's the thought from here. I don't know how it is when you're there.
I think it's a good suggestion, and I think you've noted the email address of Sister Doctor, so you can share emails. Any more questions? Yeah, in the back. Matthijs, can you have a microphone?
Thank you. In the last presentation, we had the provocative statement that short-term missions can be disturbing to local hospitals. And Sister Dr. Tembo, can you react to that statement, and also give us a little bit of insight into the structure that led to your attending the mission at Haidam, which you experienced as a training opportunity?
Local missions are very important and very good. Although they will sometimes disturb the system, but after they come, we learn. Especially me, I really benefit when they come. I told you that I have international hernia mission twice a year. When they come, I stop other activities. I join the theater with them. I learn from them. And after their departure, I continue with my daily activity. I also learn when I go to Haidam, 2 weeks. And when I go back to my hospital, it's very good. I present, I become very new, very active with a high knowledge. So I really like for this mission for the doctors to come and attend at our hospitals. It's very good.
Am I taking anybody else's time?
Thank you.
In that case, can I ask? Sorry. Also, can you tell us how it came to be that you went to Haydom? Was it that there is a faith-based relation between the hospitals, or was there a Tanzanian government system that gave you the opportunity to be at Haydom at the right time for this training, or what caused you to know and to be at Haydom for this training?
I attended one case of very bad wound, and that patient has connection with Netherlands from father of Dr. Matthias. And that man explained to me that I will go at Haydom because there are plastic surgeons who will attend, who will come there for procedures. Then I showed the interest that I also want to go to learn. So from there, they made connection with Dr. Matthias, and is how I joined the Haydom team.
I may add to that. It's a very good remark because it's difficult. We work in Haydom when we provide some training, but it's difficult to get the doctors from the area, from the district hospitals in the area, to make them, to ask them to join. We ask them, but often they cannot come because they are too busy, or maybe sometimes they are not eager to learn these kind of things because they have priorities somewhere else, or they do not know us, they have other expectations. It's sometimes difficult, but one of your points is really good. You need to have somebody who's really eager to learn, to teach him something, because otherwise it's not helping anything.
Short question? Yeah, please.
Yes, Tom. You said that there's a lot of MDs who are trained in Africa or wherever. They go abroad to high-income countries. I've heard this as well, but I was wondering if you know maybe how big this problem is, or if you have any experience with this.
I don't know the exact numbers, but you see also in South Africa, for example, that a lot of the doctors who graduate, they have to do like a rural placement first, but after they finish that they start working in private clinics in the bigger cities. And you see that all over Africa. Ethiopian doctors going to Botswana. Now Botswana has a medical university themselves, so they can start training their own people. But before, like even within Africa, going from Ethiopia, Tanzania to Botswana, and also to going to England to America. So I don't know the exact numbers, but it's quite a serious problem. And also that I think it has a training CHOs would be a good idea.
Dr. Eriksson, do you have a idea on this, or?
I think Tom touched the reality from Ethiopia. There are so many that leave. Many doctors leave Ethiopia, and also after training they leave Ethiopia. In Africa and beyond, of course. From our perspective, dealing with burns and wounds, there are not that many surgeons that are lining up because they want to learn more how to treat them. But there are many others, and I mentioned the clinical health officers that are trained, quite a number of them in Ethiopia. They are eager to learn. We have trained one, as I mentioned, only for 4 months, and a second one from the same hospital has already started training. So we need to focus on others than general surgeons. And general surgeons who stay in Ethiopia, they are also overwhelmed with clinical problems. There's no question about that. So in a hospital down south in Ethiopia where we have a focus, there's only one general surgeon for an area of, let's say, 2 million people or 3 million people. So that is what we talk about. And so we need to focus on others that are not general surgeons.
Thank you for this contribution, Dr. Eriksson. I think we've had some nice presentations and answered all the questions for now. It's time to change the sessions. You speakers will go to the to next room, and we all can stay here until the next speakers arrive. Thank you very much. Oh, je gaat het in.